All right. So our first case we're going to give to you is a 64-year-old male who has a history of prostate cancer. He had Gleason's 3+3 and was treated with CyberKnife therapy. He had a total of 36.25 gray to the prostate and seminal vesicles. About 2 years later, he initially comes in with complaints of diarrhea, fecal incontinence, recurrent E. coli urinary tract infections, and some urinary incontinence. Luke, I'll start off with you. Just getting this scenario, given the topic and everything, what are you concerned about?
So I am concerned when you see recurrent urinary tract infections and a history of fecal incontinence that this could be a patient who has gone on, especially since they had radiation, to develop a fistula. There's other pathology that it can occur, but I think it's something that certainly needs to be ruled out.
And initially, the patient did undergo a cystoscopy and evaluation by his urologist, saw some inflammation in the urethra and right at the urethral at the junction of the urethra and the bladder, but did not have a fistula at that time, according to what they had seen.
And if I can interrupt, yeah. Often what I've seen, the urologist, if he sees a little inflammation, will do a biopsy, and that is the killer. Mm-hmm. Usually that's what opens the fistula. There's nothing you can do, but that's typically what happens in real life.
He was then seen at an outside hospital with a pelvic collection. A drain was placed. Initially, the output was purulent and then looked like urine. And these are some of the images from his initial, from the CT scan. As you can see, there's a collection up here, close to, but not seeming to involve the pubis. There's another collection over here. This is the rectum back down over here, rectum over here, and rectum over here. And this is the drain over there in that area. Here's just a blow-up of one of those pictures there. Again, collection over here with the rectum over there. And again, you can see this. Unfortunately, there's a little bit of some scarring over in this direction. There's no clear fistula identified, but certainly, if we just go back for one moment there, you can see that the planes between the rectum and the urethra aren't as great as we wanted them to be. He then underwent a flexible sigmoidoscopy as well, which shows some radiation proctitis, as well as this area up in the front, and in better look at that, he now has a Foley catheter, and this is the white balloon of the Foley catheter. So, this is where we are. I'm going to open it up to the panel over here.
Well, I mean, firstly, it is unusual to have collections, because normally these decompress into the, just directly into the rectum, so it's a straightforward communication when you see it. When they're tiny, cysto may not be the way to go, and just a good old-fashioned retrograde urethrogram sometimes will give you the information much quicker, but the urologists, sort of subscribe to the Mark Twain theory. The only tool you have is a hammer. The entire world becomes a nail, so everybody gets cystoed. But just do a urethrogram, and you'll see it. And in the office, you can look from the other end. We can do with an anoscope or a finger and often see it. Sometimes that picture of the Foley is what you see with anoscopy. I mean, they come in, they've got a whacking great fistula there. So here you've got to treat the collections on top of everything else, but that's unusual. I want people to walk away thinking that's the normal scenario. I mean, I subscribe to the school that if this guy's got a fistula, as was said, you're going to need a loop ileostomy, you're going to need urinary diversion. Before you embark on any definitive treatment, generally laparoscopic loop ileostomy, and if they can't put a bladder catheter up transurethral, then they do a suprapubic. But it's got to be decompressed in both systems and let things calm down a little. On top of that, you need to also percutaneously drain, unless this stuff is accessible through the rectum or through the bladder. But if not, then percutaneously drain.
I would add to that. Of course, the other thing you're going to do is rule out the possibility of a recurrent cancer. Always has to be the first thing that's done, and you're going to look at endoscopically what the colon's like. I would generally, in this situation, give strong consideration to a loop sigmoid colostomy in a patient like this. I think functionally it's fine for them, and it allows you access to easily irrigate out that distal remnant. Then we put those patients generally on a long-standing oral antibiotic, and you're going to give them a tincture at time. But there's going to be an extensive workup followed by, you have to decide what the ultimate sphincter function of the patient is. They come in saying, the patient comes to you saying that they have fecal incontinence. That might just be fecal urea secondary to the fact that they're actually urinating out. So if they're able to hold solid stool, you want to differentiate that in their mind. And generally for us, we would get a gastrographin study from below. they'd have a cystogram or a cystography and the colonoscopy.
I would stay away from the sigmoid colostomy. As was mentioned, you may someday, if a gracilis or whatever else fails, need to go back and do a coloanal. And number one, and you may have that sigmoid colostomy at exactly a bit of length you need. But secondly, it may be radiated as well, because the patients, again, had pelvic radiation, and I don't know where their sigmoid loop was sitting, but it probably was more fixed in the pelvis than was the terminal ileum.
I think it's an excellent point to consider whether or not what you're going to do downstream, but almost always you're going to be using the loop of sigmoid that would be resected if you're going to bring something down, because the anastomosis, when you're going to redo this abdominally, you want to make sure you take out all the sigmoid colon because of the fear, as you said, that had been irradiated. So I'm very comfortable using sigmoid in that situation.
I've had such a patient recently. He was 85 years old, and you saw the urine coming out into the rectum, and he was not in a state where he would have major surgery in the future, so I gave him a diverting colostomy, and we put a suprapubic catheter in, and he's surviving like this quite well.
Yeah, that's a different story. If your management endpoint is a stoma, you're done. But if you're thinking of doing other things downstream, then personally I would go with the loop ileostomy.
I wanted to ask you, this was going to be one of my questions, the point of fecal and urinary diversion. Is the presence of the collection that makes you recommend both? When we looked at our own experience, really fecal and urinary diversion didn't really make a difference in the long run, even in patients radiated. Is that your approach? Is radiation the turning point? Everybody gets double diversion? Is the presence of the collection in this case that?
No, it's the fistula itself, because the two problems from the stool going across the fistula, any flap you put there is going to have problems because it's stool. But the problem with the urine, it's not that it's infected, but it's just voluminous, and they keep leaking, and it bathes whatever you put there, whether it's a TEM kind of advancement or a Martius flap or a gracilis, whatever you put there. I don't think they do well when there's just constant liquid leaking past it, and so they all get double diversion.
And I think from a realistic, just patient care standpoint, they're miserable. And so by diverting them and putting a Foley catheter in or a suprapubic tube, they're much more comfortable, because these things generally take a while to get worked up. And so I think they're much happier once you've done that.
You know, you're not going to rush right in because you've got an abscess. And this patient is going to be miserable. And we would put a suprapubic and do a loop ileostomy right off the bat, because, if you've ever had a Foley catheter in for a while, it is pretty miserable, and a suprapubic is much better tolerated.
So I think you guys hit a lot of the things that we went through, and in terms of making decision-making in this patient, we did put a suprapubic. We did give this patient a loop ileostomy in order to decompress, and tubes were placed in order to decompress and get rid of the infection. In his case, he actually had significant necrosis right at that vesicular urethral junction. And so we had problems. Let's say he didn't have that. Let's say we have something where you think you might be able to do a local repair. Who's going to attempt a perineal repair, and who's going to go in from the abdomen? I just want to kind of go down the line.
So I think in the absence of necrosis, I would attempt a perineal repair. Necrosis itself, especially if you have to excise all of that tissue, to me is an indication for going abdominally.
And what kind of flap would you use at the time? Let me have you do that as well.
So I generally will try to use the gracilis if possible. I think it comes over the nicest.
Yeah, I mean, I've certainly published my bias multiple times on using the gracilis, and I would say that's what I'm happiest with. So transperineal gracilis. The only caveat I'll mention that and I showed a video, I think it was at ACS this past fall, where instead of trying to do the entire thing in lithotomy, do the harvest lithotomy, and for the last several years I've been doing it this way, and then flip them prone jackknife so you can really get down nicely and high on top of the prostate, and then lay the muscle up there.
I would say that generally we end up approaching this abdominally with the gracilis flap and bringing down non-irradiated colon to do a coloanal anastomosis. At times, if it's a smaller thing, sometimes it's worth trying something transperineally to start, but our experience with that hasn't been wonderful. while it's been reported in the literature. And I think it has to do with what the size of the defect you're dealing with to start and what the fibrosis is in the pelvis.
In fact, we are collecting our cases at the moment at the Cleveland Clinic and presented them last Saturday at the Ohio Valley meeting in Columbus. So I would say it depends on the location of the fistula and the extent of the cavity of fistula. If it's lower down, if it's a small fistula, I would do the perineal approach. But if it's a big cavity, and I've seen these cases at the Cleveland Clinic, and it's located further up, away from the perineum, then I would use the transabdominal approach.
I think I agree with that. In this case, the size of the fistula seems big, and I would probably do a transabdominal approach.
So another thing that we found that you have to look at is, besides how inflamed the rectum is and how much radiation hit it took, is their pain, because a lot of these are associated with the big ulcer on the rectal side, and unless you do something that resects that ulcer, they're going to continue to have pain. Even if you have a beautiful repair, your rectum probably isn't going to work. And that was when we published our work in the urology literature. So that would be another thing we'd look at, is how painful it is, especially after the inflammation subsided. That would dictate whether we went transperineally or did a abdominally and did a coloano.
All right, we're going to switch gears a little bit. We're actually going to go.
Can we ask, why did you think you had that pelvic abscess? Because I don't think I've ever seen that in this situation.
It's hard to say. When I saw the patient, there was that big hole in the rectum. So it was hard to say kind of what had happened in between over there, and to say why that had. Perhaps it was a biopsy that had happened. The urologist did a biopsy at the time as an initial presentation with some dysuria and fecal incontinence, and at that point created it.